How come I can't copy?
And there you go. We are live. It's Pasifika Grand Rounds, Season 1, Episode 7. Go figure. I feel like we've been doing this for a minute and it's so exciting. So today is, like I said, Season 7. We have Dr. Raynald Samoa and Dr. Kilani Raphael. Our topic this month is female to male gender affirming care with the focus on Native Hawaiian Pacific Islander. I'm going to pass it on over to Dr. Kilani and we will go from there.
Naki Naki, I'm Kalani Raphael.
Sorry. I don't know what happened. Awful.
We good?
Yeah, we're good.
Okay. Thank you, Naki.
Hold on. Give me just a second here.
Okay, I think I'm good to go. Hi everyone, welcome to Pasifika Grand Rounds. My name is Kalani Raphael. I'm excited to introduce our speaker, and our talk today is female to male gender affirming care with a focus on the Native Hawaiian and Pacific Islander population. Just a few housekeeping items. Our disclaimer today, the content of this talk and all Pasifika Grand Rounds talks is provided for informational purposes only and does not intend to substitute professional medical advice, diagnosis, or treatment. And the Grand Rounds is co-sponsored by Hapi, Mapumaya, and Pasifika in medicine, I think that is. Yeah, next slide. We would like to provide both a land and a water acknowledgement here. So our land acknowledgement, we formally recognize the original stewards of the lands our institutions stand on and their connection to it. The Gabrielino Tongva tribe are recognized as the original inhabitants of these lands, and their absence in this space speaks to the violent history they endured, including their forced relocation, enslavement, and exposure to old world diseases. This led to the rapid collapse of Tongva society, ways, and their eradication. We also want to recognize our connection as the daughters and sons of Moana, the ocean that connects us, binds us to work together for better days for all our people. Okay, and for those of you who want to capture CME, please submit this code SOPQUR to cme@coh.org, or you can put your email address into the chat and we can get you your CME that way. All right, so now it's my pleasure to introduce our speaker. Dr. Raynald Samoa is a graduate from the University of Washington School of Medicine. He completed his residency and fellowship training at USC Los Angeles County General Hospital. He did his endocrinology fellowship at LA County USC and Children's Hospital Los Angeles. He's currently associate professor at the City of Hope. Dr. Samoa serves on the President's Advisory Commission on Asian American, Native Hawaiians, and Pacific Islanders, and is the co-chair of the Data Disaggregation Subcommittee. In 2022, Dr. Samoa received the Robert Wood Johnson Foundation Award for Health Equity, which is an outstanding accomplishment. He is also an investigator on a study from UC Riverside aimed at conducting a needs assessment of queer and trans Pacific Islanders residing in California, and has assisted in conducting a safety survey for LGBTQIA2S+ residents conducted by the San Gabriel Valley LGBTQ Center. Dr. Samoa is the sponsor of the LGBTQ Patient Care Fund at City of Hope. He is also co-chair of NHPI Data and Research Council, also known as DARC, and is the lead of the Healing Association of Pacific Islanders. Dr. Samoa, welcome. Look forward to your talk.
Thank you for the introduction, Kalani. I just wanted to take just a quick second to recognize that we recently had the Transgender Day of Remembrance on November 20th. As a time to reflect on a lot of the loss that's been happening due to the violence endured by our transgendered people. Um, and so this is my talk. The female to male gender affirming care with a focus on NHPI, which should provide a good discussion when we get into sort of the granular details when it comes to Native Hawaiian Pacific Islander identities. Next slide. I think we're going backwards. Should we? Oh, sorry. So there's a cultural linguistic competence and implicit bias declaration for the talk. Where we just wanted to say that the talk has taken into account the different needs in regards to cultural linguistic competency and noticing implicit bias during it. And so we do want to make sure that we bring these biases to the forefront as we were talking about health equity here. And some of that is the cisgender bias when it comes to providing gender affirming care. Okay. So some of the things that we've been doing as a series for Pasifika Grand Rounds. This was not a one-off for us. I think this was a topic because of the Mapumaya Clinic services a lot of our LGBTQ plus populations that we turned it into a series. So on May 2nd, 2023, we started the first of these talks talking about the male to female transition of gender affirming care. In July 2023, we talked about the issues regarding pediatric care when it comes to gender affirming approaches. And then in November, which is today, we're going over the female to male gender affirming care aspects. We also are getting a lot of our requests as far as topics from the Mapumaya Clinic. It's always important that you have your ear to the ground and making sure that you're benefiting the community. And so a lot of our community input has been coming from the Mapumaya Clinic. We're also involved with the Pasifika Village Initiative, which is a collaborative of queer and trans Pacific Islander organizations and advocates and experts to promote equity with our LGBTQ plus brothers and sisters. Next slide. So with that in mind, our objectives are to outline the components of gender affirming care when it comes to female to male transgender patients. We'll also want to talk about sort of the some of the attitudes providers have regarding gender affirming care to see kind of what they're struggling with. We want to go over some of the obstacles that come about as a provider when you're providing this type of gender affirming care. We'll look at treatment guidelines that oversee the female to male transgender transition. And then we'll talk about possible barriers and biases, especially when it comes to Native Hawaiian and Pacific Islander attitudes towards gender affirming care. Next slide. So it's really important to know that this is not me as an individual coming up and pushing forth my agenda. This is a studied field of medicine that's been promoted by renowned and leading medical associations, such as the American Medical Association, the American Academy of Family Practice, American Academy of Pediatrics, and the American Psychological Association, has all put forth media to promote gender affirming care, and many of them have guidelines. So we'll talk a little bit later as to why these guidelines are so important, but know that this is a body of science that we're trying to make sure people adhere to standards for. So on the first visit, when I'm seeing a patient that's interested in gender affirming care, or transitioning, if you will. That's when we want to make sure that we are clear about what our objectives are. So Teleba means that you prepare the field because you're going to start farming. And so in that preparation, it's extremely important that you try to establish trust. Um, there's absolutely no benefit to have a mistrusting or adversarial relationship with patients, even though you may not understand them. There's always a way to find common ground. Um, uh, and also to know that as a provider, you are in a position of power and leverage. And so reaching out to make sure that patients understand that you have their best interests at heart is, how we adhere to being the best provider we can for our patients. Um, of course, like standard medical practice, you want to obtain a good history. You also want to see where they're at in regards to their gender dysphoria. Um, uh, I say that kind of loosely because gender dysphoria is kind of being replaced. We'll talk a little bit about that later, as it's a little sort of pathologic based. Um, we want to make sure on that visit that we are clear about our goals of treatment. Oftentimes, when you have patients who are very dissatisfied with their care, it's because realistic goals have not been agreed upon. So it's really, really important for you to do that up front. You want to get a family history, social history, which includes any past drug use, and then what are their social determinants, what things do they find difficult in regards to their access, as well as their job. This we'll talk more about when we talk about transitioning. This is a subgroup that is very prone to eating disorders, so you want to make sure you screen for that as well. Domestic violence also occurs, in this situation, so you want to make sure you screen for that, as well as a sexual history, employment history, as far as like what are the obstacles they get from work when they're transitioning, and then immunizations, because you want to make sure you stay up to date to those. Next slide. So as I said before, there are different ways to transition, and all of them sort of affect each other. So it's always good to know where patients are in regards to they are in the different types of transition. So those different types include social. So social is where they are in transitioning in regards to themselves and the people close to them. It's also like, are you out at work? Have you told your immediate family, your extended family, your friends? Where are you in that? That's extremely important because that type of social support has shown to be very impactful when it comes to patient outcomes. Usually, when there's issue regarding social transitions, that's when oftentimes I refer patients or elicit help from like social workers, psychologists, therapists, and counselors. And then there's the medical transition. So this is usually, where patients come to see me in clinic. It's usually had by physicians and nurse practitioners, PAs as well. And this is the biological transition. So this can be, hormonal therapy, but also includes surgical as well. And then there's legal transition. So this is changing of one's name, changing their status on their documents, like their driver's license, their passport. And so these usually requires a fair amount of knowledge in the legal realm. And so oftentimes I usually don't refer to lawyers particularly. I don't know that network, but there are a ton of community advocates out there that have these types of services available for people who are transitioning legally. The Utopia Washington group, which is what Mapu Maya is part of, they have an excellent legal resource for people who are transitioning. And then these transitions require sort of a multidisciplinary approach when you're dealing with them. So let's go over sort of gender terminology, because people still kind of struggle a little bit with trying to understand what gender is. And so usually people are very familiar with sort of cisgender, and they're beginning more familiar with transgender. But there are those that don't completely fall into those two categories. So cisgender, as you know, is a gender identity that aligns with our cultural notions of the gender that you were assigned at birth. And then transgender are persons who identify that differ from their assigned gender or sex at birth, and the conventional notions that go along with that gender assignment. So in between those can be gender diverse, non-conforming, non-binary, gender queer, gender fluid. This is someone that is sitting somewhere along the spectrum, and these people just view their gender on a spectrum rather than fitting into the binary categories of male or female. Next slide. And then, so it's really good to know that gender identity is completely different from sexual orientation or sexuality. Sexual orientation is the concept of one's feelings and attractions and desires towards another person. And then there's different categories within that sexual orientation, that are identified as lesbian, gay, bisexual. Transgender is not really in that sexual orientation category. But there's also questioning and queer for people who don't know exactly where they fit in that sexual orientation spectrum. And then there's, the ends of the spectrum, like pansexual, where there's an attraction to the person, not so much defined by their sex. And then asexual, one that is not attracted to anywhere on the spectrum. Then that is usually defined by sexual behaviors. So oftentimes when people have trouble with trying to determine sexuality, it's easier to discuss what sexual behaviors they partake in. And so those categories are a lot more discrete. And so usually, like, what we describe sexuality as is how one identifies and how they identify those they are attracted to. Remember, when we're talking about sexual orientation, you do not need to discuss sexual orientation or need to have it defined in patients in younger pre-adolescent patients to address gender dysmorphia at that age, because the two are very separate concepts. Next slide. And as I said before, these are not just sort of random things that we're asking you to do for transgender patients. There is a strict standard of care that's published under the WPATH and provides a very comprehensive description of what those guidelines are when it comes to gender affirming care. And these have been, a lot of it is evidence-based, some of it is sort of more expert opinion, but all of it has, it's rooted in strong guideline development. Next slide. Establishing goals of therapy. As I said before, this is really, really important to do on the first visit. And if you don't get it all the way completely done on the first visit, it's always good to revisit it every time a patient comes in to see you. Oh wait, go back to the previous one. Yeah. So the usual aim of transgender hormone therapy is to induce physical changes that match the patient's gender identity. But what those exact changes are must be made very, very clear. Sometimes the goal isn't to completely transition. There are people that do not want to undergo surgery. Other times, people want some physical characteristics, but not all the ones that are attributed to sort of the male gender. Um, the ceiling of hormonal treatment is to maintain hormonal levels in the normal physiological range. Um, and that's to produce the harmful risk of excess hormones or excess male hormones. And we'll talk about some of those negative side effects later on in the talk. Um, uh, Historically, transgender individuals had to sort of resort to self-medication for a variety of reasons. A lot of that was alienation by standard medical practice. So, you know, there's been stories of my patients saying they came to me after there was a delay of initiation of hormonal therapy that caused them to experiment, and they finally decided to refer themselves to experts so that they wouldn't put their lives in jeopardy. Now, the typical goal, as I said before, is to sort of stop menses and induce what we call virilization. So that's a masculization of features, which includes sort of the male pattern of sexual facial hair, change in voice, male physical contours. And the principal hormone of treatment that we use to produce these effects is testosterone. Now, it should be very clear what the guidelines say is the criteria for starting this hormonal treatment. You have to have persistent, well-documented gender dysphoria and gender incongruence. These hormones come with side effects. They come with a risk of harm. So if you're going to undergo this type of treatment, you have to make sure that the benefit far outweighs the risk. And the benefit is only reaped when there is very clear gender dysphoria or gender incongruence. They have to be able to make a well-informed decision. Someone who is paralyzed by anxiety is not in the place to make a well-informed decision. Someone who is struggling with drug addiction is not usually in the place to make a well-informed decision, usually. And then you want to also make sure that there's relevant medical and mental health issues that are well controlled. Like I said, these testosterone in certain areas can cause problems. And so you want to make sure that their side effects are minimized, the risk of side effects are minimized, because you've controlled for a lot of their potential medical complications from therapy. Next slide. So testosterone therapy comes in many routes. There are injectables. That's probably the more sure way of getting it. Usually that's the route I recommend in the beginning. There are gels, there's transdermal patches, there's buccal tablets. There's also a implantable hormone therapy. All of these have pros and cons. So you have to go into a very detailed discussion about what the pros and cons are for each different modality. So testosterone injections and gels are usually what we recommend to start with. The higher testosterone levels are achieved with parental therapy, but the downside is that it starts to peter off before the next dose is due. And as you can see, we usually start with 50 to 100 milligrams of testosterone and anthonate or testosterone cypionate weekly or every 2 weeks. I usually started every 2 weeks to introduce the hormone to get one's body used to it. We usually cap off at about 200 milligrams every 2 weeks. We used to be able to only administer the testosterone injections intramuscularly, but I think over the past 10 years, we've been able to show that you get adequate levels with subcutaneous injections. For those of you who don't know, the subcutaneous injection is just under the skin, where intramuscular is deeper. Um, uh, but the FDA hasn't approved the sub-Q route yet. But endocrinologists are prescribing the subcutaneous route currently. Let's see. We usually measure levels when somebody's on testosterone injections. Um, uh, Halfway between the injections. So if you're doing it every 2 weeks, you would get it at the end of 1 week. If you're doing it weekly, you would get it after 3 to 4 days. That's sort of to see where the peak is, or sort of what the mid dose level is. And then some people check it 24 hours after, just to see how high the testosterone levels are going to be. I don't do that. Some clinicians start with lower dose of testosterone because transgender men are often smaller than average men in size. Like I said, I use a smaller dose in the beginning just because to get the body used to seeing testosterone at that dose. The goal remains to achieve normal male levels that can be done as quickly as practically can. We use gels, but the virilization may be slower. The gels are actually kind of nice because the level doesn't fluctuate as much because you have to administer the gel daily. Some clinicians switch to the gels once the virilization is complete, just for that reason. It helps avoid like super high levels of testosterone because it doesn't fluctuate as much because you're administering it daily. Let's see. Next slide. As I said before, these are the different ways to get it. The testosterone anti-incipionate is usually given once a week to once every 2 weeks. The testosterone andeconate is the long-acting one. That is given every 10 to 12 weeks. I don't think that's available in the U.S. At least last I checked, it wasn't. So it's hardly prescribed here. There's the transdermal formulations like testosterone gel 1% or 1.6%. There's also a patch. It's a lot cleaner than the gel. You have to remember to wash your hands with the gel because you have active hormone. So anybody you come in contact with, or like if you're taking care of young children, they're going to get exposed if you don't wash your hands appropriately. The testosterone patch is a lot nicer because it's very clean. You don't get gel on your hands, and then the patch you administer daily. Next slide. So the effects of therapy. One is the sexual hair patterns observed in pubertal boys. And so it usually shows up on the upper lip first, and then the chin, then the cheeks. The amount of hair growth might be predicted in the pattern that their male members of the family have. So that's one way to sort of predict how their hair is going to show up. It's not a surefire method, but it is one way to sort of predict. But it also is a way to predict when you're going to get male pattern baldness as well. You expect the deepening of the voice. Now, once you get the voice changing, that may not change. Especially if you've been doing testosterone for years, because you'll have the structural change of your larynx and the oropharyngeal area. Your body composition. Usually testosterone can lead to a reduction in subcutaneous fat. It does if you don't work out, though, it doesn't mean testosterone by itself is just going to keep making you more muscular. You can get higher amounts of abdominal fat, the circumferential fat. The increase in lean body mass is about 4 kilos, so about 10 pounds. And the increase in the body weight, like I said, might be a lot more. Acne occurs at a fair amount. A little less than half of patients develop acne. And then you can get enlargement of the clitoris. It varies a lot as to how that changes. A big thing that happens, though, is there's a huge increase in libido. Most of my patients report the significant increase in their sexual desire after starting testosterone. So as far as breasts go, testosterone sometimes can cause a decrease in breast size. It usually doesn't make them go away, though. Some of the guidelines have suggested a hysterectomy to avoid cancer risk from endometrial exposure to androgen. However, there's not a lot of evidence behind decreasing the risk of endometrial cancer from a hysterectomy. Nor is it really demonstrated or reported, more or less, in transgender men receiving androgen therapy. The lower height and broader hip configuration in transgender men compared with normal transgender men does not change with testosterone treatment. So you don't expect somebody to grow taller just because they're on testosterone. And the sort of your hips may or may not change with testosterone. Sometimes, we are recommend a oophorectomy when we're using really high doses of testosterone to produce some of these changes. An oophorectomy is the removal of ovaries, and it seems that when ovaries are removed, testosterone seems to be a lot more effective at lower doses to produce some of the virilization that we're talking about. Next slide. So monitoring, usually when we have patients on testosterone treatment, we see them every 3 months in the first year, just to make sure that their blood counts aren't too high, and that their cardiovascular risks are managed. Usually after the first year, if everything seems to be copacetic, we move to 1 to 2 times per year to monitor for appropriate virilization. And to screen for any adverse reactions. And once again, the goal is to sort of keep testosterone in the normal physiologic male range. And I said before, we usually do a mid-dose check of testosterone. Most labs, although I've seen this level be lower, we're shooting for a testosterone level between 400 to 700. Nanograms per deciliter. And like I said, that's lab specific, though, so you want to make sure you check with their ranges. For testosterone undecanate, testosterone should be measured just before the following injection. If the level is greater than 400 nanograms per deciliter, you would consider increasing the interval that they're getting it. Because remember, they get theirs 10 to 12 weeks. For transdermal testosterone, the level can be measured no sooner after 1 week of daily application, at least 2 hours after the application, or else you're going to get sort of like a false, not false, but you have a high read that's not very clinically significant. You can get polycythemia rubra, which is a elevation of your red blood cells with excess testosterone. So you kind of want to make sure you measure hematocrit and hemoglobin at baseline and every 3 months in the first year, and then less often as the years go by. High levels of red blood cells can cause strokes. They can cause a whole host of other issues. You do want to screen for osteoporosis only because you want a baseline. Somebody who's not adherent to therapy, that they're not taking the testosterone as prescribed, especially if one had an oophorectomy, will be at risk for developing osteoporosis. So you want to make sure you have at least a baseline to compare. If they still have cervical tissue present, they didn't get a hysterectomy, they should still get routine checkups for that, based on the guidelines by the American College of Obstetricians and Gynecologists, or ACOG. And then, like I said, oophorectomy can be considered after completion of hormonal transition, mostly to just see if you can get the testosterone dose down. And then you still want to do breast exams. If a mastectomy is not performed, then consider mammograms as recommended by the American Cancer Society. If a mastectomy is performed, a physical exam, self-exam should be good enough. Next slide. So some of the things that you have to be mindful of when you're dealing with patients with that are getting gender affirming care from female to male. One is for gender affirming care who have intact breasts, they still need routine screening. So mammograms, as the guidelines suggest. If they got a mastectomy, then like I said, the yearly exams are good enough. They also have to be screened for cervical cancer. If you have a cervix still intact because you haven't had a hysterectomy, then they should still get the routine screening. No cervix, no need for screening. Prostate cancer, not applicable. Cardiovascular disease, because testosterone can increase your risk of heart attacks. So you want to make sure you're screening them. You're checking their cholesterol, their blood pressure. Also, there's a high risk of diabetes with testosterone. So you want to do routine screening for their blood sugar control. And then, like I said, on testosterone, you want to check their cholesterol at least once a year. Osteoporosis, you should do a bone density on all your patients that are over 65. Between 50 and 65, you want to screen your patients for osteoporosis if they've been off hormones for more than 5 years, because they're at greater risk at that point. Next slide. So let's go over a case real quick so we can sort of put these skills to practice. So we had a patient named Alo. Alo is completely fictional. Is a 40-year-old transgender Pacific Islander male that sees you because he would like to start hormonal therapy with testosterone. He tells you that his pronouns are he and him. He is out to his close friends and a few siblings. He is still having periods. He has never been treated or used hormones in the past. He works as an electrician. He is single and is not sure of his sexual orientation yet. He has had 5 different sexual partners in 3 years, which have included women and men, and have not used any forms of protection in the past. He smokes only at social events and has 4 to 5 beers a day on the weekends. He denies any illicit drug use except for occasional marijuana use. He denies any history of anxiety, depression, suicidal, or homicidal ideation, although he does not report he feels lonely often. He has not made any changes to any of his identification or legal documents. His dead name is Sarah, and would like his health records to change his name formally to Alo. For those of you who don't remember from previous talks, the dead name is usually the name at birth that someone has, that usually they call it a dead name because they no longer want to use it during their transition. So what do you do now? Next slide. So first steps, as we said before, establish goals. What type of transition has Alo gone or is going through? So social-wise, he's only out to a limited number of people, just to a couple siblings and friends. You want to make sure that you do a full assessment as to what his plans are to socially transition fully, because once you start transitioning, you don't have to tell people, right? They're going to see the viralization. And then what are your goals for medical transition? Is the medical transition, like, what types of viralization aspects is the patient wanting to achieve? Do they want their voice to change? Do they want facial hair? Do they want morphologic changes in regards to muscle development? Those are the things that you want to make clear. And then what is the full transition? Are they interested in undergoing bottom surgery and mastectomies? And then what is his plans for legal transition? Is he planning to change his documents? It's very in this day and age, when you have people kind of having to deal with, like, sort of the bathroom issue, if you will, having sort of legal changes on your documents, it provides some level of protection for them. So you also want to make sure you're aware of legal resources out there for these patients that are local, so that you can refer them to. So after talking with them, patient is interested in full transition, wants to do both top and bottom surgery, wants to eventually change his legal documents, and plans to do the full social transition as well. Next slide. Next step, criteria for starting. Remember, we'll start testosterone injections or testosterone replacement therapy if they meet criteria for starting. So it's really, really clear. You have to document gender dysphoria or gender incongruence. Are they unhappy because of the gender that they've been assigned at birth? Has it been problematic in their being able to sort of be happy with their existence? That sort of evidence should be documented in your notes, so that this patient is going to benefit more than the risk of therapy. Can they make a good decision? It looks like there's no signs that he's not capable of making good decisions based on the medical history we were able to retrieve. So that looks like it's a go. Are there any medical or mental health issues that we need to control? Mental, no. Looks like we still have some blood work to do to make sure there's no underlying medical conditions that might be worsened with testosterone therapy. Next slide. So we talked about sort of gender dysphoria kind of being frowned upon as a term to diagnose patients. So gender dysphoria is a DSM-10 code. Marks differences expressed between expressed and experienced gender and genders others would assign. It must continue for at least 6 months. It has to cause clinically significant distress or impairment in areas of their life. And in children, they desire to be the other gender must be present and verbalized. Gender dysphoria is very pathologically based. It's a little akin to homosexuality. Homosexuality used to be a DSM-4 code. and it made it look like it was an illness. And so that's what people are trying to move away from, is looking at transgender as a illness, rather than just a condition that requires medical assistance. Next slide. So what people are more interested in using is this term gender diversity. So gender diversity has an ICD-10 code, E34.9. It's patient-centered developmental care and allows for flexibility in clinical judgment. So it ascribes to the idea that gender is universal, it's normal. Gender diversity is a variance. That's what we expect of biological species and human development. Diversity doesn't equal deviance. Gender diversity may improve care. As not looking at it as a pathologically based, you might get more engagement from patients. It can help decrease minority stress, and it advocates for another form of reproductive justice. And its aim is to advocate and empower vulnerable populations. Next slide. So, as we said before, criteria for starting, persistent, well-documented dysphoria and gender congruence. He knows loneliness is due to feeling isolated because his gender doesn't match his physical makeup. Capacity demonstrates no mood disorder. Referred to CBO for legal counseling. And then relevant medical or mental health issues are well controlled. So, you got to do a pregnancy test. You really shouldn't be on testosterone if you're pregnant. You want to do a CBC to get a baseline hemoglobin or hematocrit, because as we said before, testosterone can raise that into abnormal levels. You need a CMP to look at kidney function as well as liver enzymes. You check a testosterone level at baseline. Sometimes patients come in and have been experimenting, so you'll realize that the testosterone levels are higher than what you expected. You want to check growth hormone, luteinizing hormone. These are, as well as FSH. That didn't make it to the list, but so growth hormone, because sometimes there's a in those who want to sort of build muscle quickly, you can abuse growth hormone. Luteinizing hormone and FSH are gonadotropin, so they sort of help us monitor hormonal levels. You should screen for sexually transmitted infections. You want to check an estradiol level just for a baseline. You also want to do a mammogram as part of routine care, because testosterone can alter that. And then refer to a therapist as needed. I send everybody to a therapist just because they can help with stress management techniques. And I don't use the referral to the therapist as something that's pathologically based, more as a resource to help anyone that would be going through a transition. Obstacles. So a couple of the obstacles I've seen in promoting gender affirming care in our communities has been sort of defining gender identity and sexual orientation for Native Hawaiians and Pacific Islanders. I know the LGBTQI Two-Spirit IA plus moniker is long, and yet, even as long as it is, it doesn't do much to sort of describe the indigenous identities of queer and trans Pacific Islanders. We'll talk about that more in detail in a little bit. There's also community and cultural taboos when it comes to gender affirming care. I don't think it's indigenous, these taboos. A lot of them have come from sort of the moral code that was brought with Christianity, that's replaced a lot of indigenous thinking around gender identity. And so that run amok against people who are trying to live authentically. And unwelcoming healthcare spaces. Oftentimes when you're seeking care in Pacific Island spaces, because our community is so small, we tend to talk a lot. So confidentiality can be a real big problem that can be a danger sign. And the danger behind those types of environments is that you'll have people go experiment on their own instead of going to a place that's designated to help them, like a healthcare facility. Next slide. So the work that we're doing with the Pasifika Village Institute talks about Pacific Indigenous queer and trans identities. And there are many to speak of. A lot of these identities have actually been eradicated. Some have survived well, but have been redefined. For instance, the term Mahu. My understanding of Mahu was distinctly male to female transgender Native Hawaiians. After doing research and speaking to experts in that area, Mahu seems to be less about sex, but more about male and female energy. How Mahu has been defined to me is anything that falls in between the male and female energy can be considered Mahu, or the third gender. And so that leaves that's a wide spectrum. Then we have Fa'afafine. So Fa'afafine, I think, has been bastardized to just mean like transgender Samoan from male to female. After sort of doing a lot harder research on the term Fa'afafine, the indigenous definition of Fa'afafine does not fit cleanly into the categories of Western gender identity and sexual orientation. The literal translation of Fa'afafine is in a manner of a woman, and that has a myriad of definitions. And so you can have masculine presenting Fa'afafine. I myself would identify as Fa'afafine, and yet because of the sort of Western notion of Fa'afafine and how it's been translated into English, many people would not see that. Right? Fakaleiti is also the same thing. Fakafine is actually their indigenous word, but Fakaleiti has been used more. Fakaleiti was actually a word that was introduced by a white researcher because Fakaleiti means in the manner of a lady, but Leiti is the translation of the word lady. And so it's a post-colonial word that's now being used more by the community. Oh, that's the other thing too, is the indigenous definitions are not always old definitions. A lot of the Guamanian terms, the Guahan terms, the Chamorro and Chamorro terms for queer and trans Chamorro and Chamorro are words that have been agreed upon by sort of modern queer and trans Chamorro people. And I think that's the thing about indigenous. It doesn't mean that it's old. It just means it's been agreed upon by the culture. One particular community that I find very interesting had almost a complete erasure of all of their queer and trans identities. In Fiji, the terms they use are more regional. So different parts of Fiji use different terms. And a lot of them had been abandoned once Christianity was adopted. But there's a resurgence now to bring those words back and to redefine them. Vakaselewalewa is one of those words. Um, there's I found out there's a whole host of them. There's actually a current effort now by an advocacy group in Fiji to reclaim a lot of those words in the region and introduce them into policy so that it can be used. Fa'atane is the female to male version of the Fa'afafine that's used in Samoa. Um, Fa'atane are not as visible as Fa'afafine. It's still unclear to me as to why that is, but it's important to make sure that they've been around forever, um, and you know their needs are specifically unique to that group, and they're considered sort of the Papafine and Fatane are considered the third and fourth genders of Samoa. Palopa is a word from the Solomon Islands, or no, sorry, apologies. I think it's Papua New Guinea. And Akavaine is from UA. As I said before, there's way more terms than this. And could you think of, they're starting to use um, the acronyms MMFA, VAPF, A in the Pacific Plus, just so you know. Next slide. Let's do the quiz. Shall we do the quiz? Go back a couple. Actually, one more back. Okay, quiz. True or false? Straight appearing, masculine presenting gay Samoan men are not Fa'afafine. Well, you should know the answer to that. Yeah. Native Hawaiian lesbian women can be referred to as mahu. If you're listening, you should know that answer too. Mala and Kauri are appropriate terms to identify queer and trans Pacific Islanders. And here's a bonus. Fa'atane from Samoa is often referred to as A, Freddie, B, Roger, C, Prince Harry. Kalani and Naki, you guys want to unmute? I'm curious as to see what your answers are for this one. Okay, I'll catch you at the end of the thing. All right. Next slide. So like I said, there's current efforts going on to revive a lot of the queer and trans Pacific Island indigenous definitions. It's good. People should know that although these identities are being reclaimed, they're still being defined. Because of centuries of erasure due to colonial violence. These terms are the discussions are now being had to update these definitions. And they're important parts of our culture because they've existed, for centuries. Next slide. Next slide. What happened? Hello? Am I frozen? Next slide, please. Hello. Hello, Naki. All right. Do we have anybody advancing slides? Hello. Let me see. Oh wait, hold on. Hey, love.
Sorry, I'm frozen. Give me a second.
Okay. All right, we'll stall. So actually the rest of the talk is about genital reconstruction surgery, as well as mastectomies. I saved those for last because that tends to be the more salacious part of like gender affirming care. People tend to be so focused on those aspects of gender affirming care that they completely miss the point of the real transition, which is the patient um, trying to be more authentic. Um, um, oh, hi, Mena. Can you advance the slide? I think your mom's frozen. So here's the gender confirmation surgery or gender affirming surgery, as we said. It's the most invasive step. It's usually, permanent. Um, so you have to be really clear that this is your goal when you're providing treatment, because it's not always the goal. Um, the same criteria for starting hormonal treatment fits with criteria whether you should do gender affirming surgery. The only difference is that for gender affirming surgery, we usually recommend that somebody's been on hormonal therapy for at least a year before they consider gender affirming surgery. Hi. Um, and so um, that's it. I think there's a couple slides at the end that we just want to make sure that uh, we remember to send in your CME code. Um, and then don't forget we have upcoming talks. I think we're scheduled all the way out to June regarding our Pasifika Grand Rounds. And so a couple other things we can use to make the space more affirming to our transgender patients is to train the staff on an agreed approach. Um, Asking people what pronouns you use, I think, is safe ground. You'll have people that are offended by it, but I'm not sure what the harm is if you ask somebody what their pronouns are. Avoid saying statements like identify as trans male, rather so and so is a trans male. Once again, the dead name means the birth name of someone who has changed their name as part of their social transition. So you want to make sure that that's noted to the staff, that somebody does not want to be referred to their dead name. It's akin to misgendering someone. And then their electronic records should also have their preferred pronouns as well. Next slide. Here's some references. So if you have really good eyes and you're watching this at home, you can pause it to see the references for the different slides that we use. And then that's it. 634.
Great job.
That's
you did a great job.
Thanks.
And I learned a lot.
Can you go back to that quiz slide? I want to
Yes.
start there with Kalani. Are you on? Is Kalani
Let me bring
in?
him on. Yeah.
Okay.
So
right there, right there.
Okay.
So,
Appearance,
so
masculine.
you should get number one right? What's your answer for number one?
I think you should go through them all because, just for everyone. I
Yeah,
mean, I learned I've never heard a lot of these words, so I was,
Me too.
yeah. So go
me
through them.
too.
Yeah.
Me too. Me too. So, first forward, true, false. Straight appearing masculine, presenting gay, some women are not fafafinge. That's false, right?
Yeah.
Um, so our definition of fafafinge is not the same as the gender identity and sexual orientation definitions of the West. That's you can have different presenting types of fafafinge. One of the things we found is that um, different presenting fafafinge have different struggles. Um, whereas like feminine presenting fafafinge have a harder time in Western spaces, like in the US because of the usual problems with transphobia. Masculine presenting fafafinge have a harder time in Samoan circles because they're not the stereotypical fafafinge. So they're less understood. Whereas one would easily pick up feminine presenting fafafinge to watch children, to care for elders, to be in that space. A masculine presenting fafafinge, not so much. You know, so different struggles for the continuum of fafafinge. Um,
Well,
Second,
I love that I love that we've acknowledged, like, now recently, that we're acknowledging that the Samoans have three genders, right?
yeah,
Female,
cool.
male, and Papafina. Oh, four. But to us, it's not like it's normal for us that we've had this third and fourth gender. We've always, for as
Yeah,
long, but now coming, it's a, especially in the film Next Goal Win, they brought it up how it was, we're the third, fourth gender. And to me, it's normal, but outside of the island, it's like, what do you mean? What,
yeah,
that's a man or that's a woman? Their mindset is so small. And I didn't realize it until just up until now. People have been talking about it's the third, fourth gender. And to me, it's like, oh, okay, well, it's just normal for us, right? So I love that.
yeah. That's an important point, Naki, because there was a British researcher that came to Samoa, and her theory was fafafinges were boys that were raised as girls when there were not enough girls in the family.
Yeah.
Completely false, right? Like, but this is a
Way off.
narrative that made it to national TV. It was on National Geographic. It
Mhm.
got so much traffic, got so much momentum because it was so exotic. You
Yeah.
know, when Samoans knew the truth, right?
Yeah.
Like, and it was very, that's the thing. Like, people go, oh well, at least people are talking about fafafinge, and I'm like, they're talking about a myth, right?
Mhm.
And the problem with myths is that myths don't get equal rights. Myths don't get equal treatment, you know. And so, anyway, let me get off the soapbox.
Yes.
Um, the second question: Native Hawaiian lesbian women can be referred to as mahu too.
Ah.
So this I just learned, right?
Mhm.
This is true. This is true.
Oh,
So yeah, so this is what I was talking about. That Mahu is more about the interspace between masculine and female energy. So
oh, okay.
anything that falls within there, fits the term Mahu. Um, Now that I think that's the other thing about the word Mahu was it got hijacked once the Western moral code came, and so to them the most extreme Mahu was the female transgender.
Mm.
So to Christian minds, that's what they define Mahu as. right? And so everyone kind of picked that up. But if you listen to people like Kumuhina, you'll see that the understanding of Mahu goes beyond sort of what Western traditional definitions are. Okay, let's go to the. Did you have comment, Kalani?
Nope.
Yeah. Um, Mala and Kauri are appropriate terms to identify queer and trans Pacific Islanders.
What is this? Mala and Quarry?
Kauri.
Cowrie.
Yeah.
Okay.
It
They are
wasn't on
not.
your slides, so I'm gonna say no.
Yeah.
No.
I
no.
know. I didn't see that one.
So Mala, it's commonly used in Samoan language. Like it's a colloquial. We say Mala all the time. Mala is now being understood by a lot of Fa'afafine advocates as a slur. So Kalani, so the word Mala actually means cursed. And I think it was a slang word. It's kind of like the N word, right? Like it was a word that was used to demean a group of people, and then the group of people came back to reclaim it. We're still kind of on the fence with Mala. Like I stopped using it only because it kind of lends itself to the transphobia, as being identified as a curse. Kauri is the Fijian word for non-cis or just queer. Like Kauri actually, a lot of indigenous Fijians view it as a slur. What's interesting about the word Kauri is that it has Indian roots. It has Asian Indian roots. And it too, kind of like the N word, was being promoted as a general term to sort of subjugate people that were different, and so I think especially the younger indigenous Fijians are starting to condemn the word. So that's it. So our bonus. A Fatane from Samoa is often referred to, and you have a 33% chance. A, Freddie, B, Roger, C, Prince Harry.
Wait. Is all of the above an option?
No, it's not.
A Whakatane is often referred to as Freddie.
I'm gonna go with Roger.
It's a Roger.
Hey,
It's
I
Roger.
learned something new.
Pure luck.
And why is that?
There's a documentary out that speaks to it beautifully, where the Fatane, like you said, they were less public, they were less visualized. They're kind of a quieter community. And so there's a group called the Fa'afafine Association that is in Samoa, the independent state of Samoa. And so one of the leaders there, whose first name was Roger, kept urging the group to start to form their organization. And they would be supported by the Fa'afafine organization. So out of respect, the Fatani organization that came out of that named themselves the Rogers.
Got it.
Yeah, it's actually a really cool documentary. I think it's online somewhere. It's easy to find on Google. But that's it. That's it.
I learned so much. So Mala and Corey, that's a no.
Yeah.
Well, thank you for that.
Oh, you're welcome.
We'll go back to our slide. These are our reference slides. Screenshot if need be. Any questions? I didn't see any. And here are our future talks. We're on every third Thursday of the month. You'll usually see Raynald or Dr. Kalani on. And so next month, you want to tell us who we're going to have?
We do. So City of Hope is a top 10 cancer center in the nation. And so it provides a lot of cancer survivorship models. Um, and so we are lucky to have a founder of one of the founders of our cancer survivorship program. She's been doing it for over 20 years. She's actually set to retire this year, so I grabbed her before she left. Carla Wilson, and then Hannah Koma is scheduled to sort of fill in for. I think it's just going to be Carla that's doing the talk in December, but it should be a really good discussion.
Awesome.
Yeah. And
Looking
then
forward to that. And then
don't forget, go ahead.
We offer CME credits, AMA, PRA category, 1 credit during this live session only. So if you caught the code, if you missed it, it's down here. It's been there all through the show at the bottom of the screen. And then we value your feedback. So please complete the evaluation that will be emailed to you after you send in the code. And there's your code. And then submit your code via cme@coh.org. And so we can record your attendance and then send you the survey and send you some credit. If you would like to be added to the Outlook reminder list, again, email cme@coh.org. Yay! Thank you, Dr. Samoa, Dr. Kalani Raphael. We will see you next month, maybe. Yes, next month.
Next month, Dr. Malik Fuimono is moderating.
Yes. So we will see you next month. Thank you both so much for your time. We appreciate it. And we'll see you next month, Pasifika Grand Rounds.